I am Professor Sanjeewa Padumadasa of the Department of Obstetrics and Gynaecology, Faculty of Medicine, University of Kelaniya, Sri Lanka. Today, I will take you through the management of shoulder dystocia, what and what not to do. Shoulder dystocia is the condition where, following the delivery of the head, the baby's anterior shoulder is impacted behind the maternal pelvis symphysis. Bilateral shoulder dystocia, where the baby's posterior shoulder is also above the pelvic brim, is only a theoretical possibility because the posterior shoulder would have usually descended below the sacral promontory and into the sacral hollow. Shoulder dystocia is a serious obstetric emergency because birth asphyxia can occur within a short period of time. Once the baby's head has been delivered, the uterine contractions would lead to a reduction in the blood flow in the intervillous space. In addition, once the baby's head is out, the baby would want to breathe, but it can't because the chest is tightly compressed within the maternal pelvis. There is only about 3 to 4 minutes before permanent hypoxic brain damage occurs. However, if the fetus is already compromised, serious asphyxia can occur within a very short period of time. Although there are risk factors for shoulder dystocia, the vast majority of cases occur in women with no risk factors. Therefore, for all practical purposes, shoulder dystocia is neither predictable nor preventable. That is why every birth attendant should be mindful about the possibility of shoulder dystocia with any vaginal delivery and be conversant with at least its initial management. Once the fetal head is delivered, the shoulders should deliver spontaneously or with gentle axial traction on the fetal head. The fetal chin would be tightly pressed against the maternal perineum. This is known as the turtleneck sign. Sometimes, although restitution may have occurred, external rotation would not have taken place. Once shoulder dystocia is diagnosed, help should be summoned immediately. This includes the most experienced obstetrician on site, the neonatal team, and personnel to place the woman in various positions that are required for delivery.
Shoulder dystocia, leg room 3, I need help!
Once shoulder dystocia is diagnosed, there are certain actions that need to be avoided. One should not apply excessive downward traction on the fetal head. This is the main reason for brachial plexus injury. Fundal pressure should be avoided because it aggravates the impaction of the anterior shoulder behind the pubic symphysis. Furthermore, it carries a risk of uterine rupture. Similarly, maternal pushing should be discouraged.
Mrs. Emily, we have a situation whereby your baby's shoulders are stuck. Don't worry, we are doing everything that is required. Please don't push unless we ask you to do so.
The woman should be brought to the low edge of the bed and placed in Merkabah's position, that is, flexed at the knees and hyperflexed at the hips. Take her to the low edge of the bed. Now take her knees towards her chest, both at the same time. This Merkabah's position leads to only a slight increase in the anteroposterior diameter of the pelvic inlet. But more importantly, it brings the longitudinal axis of the pelvis in line with the desired direction of traction required for delivery. The most experienced obstetrician should place him or herself in between the maternal thighs and apply gentle axial traction on the fetal head. If that does not work, the hyperflexed leg should be slightly abducted to make room for a third assistant to squeeze in order to apply suprapubic pressure. aim of applying superficial pressure is to rotate the baby's shoulders, which are stuck in an anteroposterior diameter of the pelvic inlet, into a wider oblique diameter of the pelvis. And applying pressure from the posterior aspect of the anterior shoulder has the additional advantage of causing adduction of the anterior shoulder, which leads to a reduction in the effective transverse diameter of the shoulders. How will you know which side the baby's back is on? If restitution has taken place, the back would obviously be opposite to where the baby's face is pointing. If restitution has not taken place, one may have an idea where the back is from previous abdominal or vaginal examinations. And even if one doesn't know this, it doesn't really matter, because the main aim of applying superficial pressure is to rotate the shoulders to a wider oblique diameter of the pelvis. So superficial pressure can be applied in either direction, from the maternal left towards the maternal right, or even from the maternal right towards the maternal left. Superficial pressure is applied with the heel of the hand, one on top of the other, with either continuous or rocking movements. If the shoulder dystocia is not resolved by these first line measures, then one should move into second line measures, internal maneuvers. There are two types of internal maneuvers. Maneuvers involving the rotation of the shoulders and those involving the delivery of the posterior arm. The anterior aspect of the vagina is filled with the fetus, and it is the posterior aspect of the vagina that has space to accommodate the hand of the operator. In addition, the posterior shoulder would have descended below the sacral promontory and would now be lying in the sacral hollow, making it accessible for delivery. Shoulder dystocia is an emergency concerning the bony maternal pelvis and is not a soft tissue problem. An episiotomy by itself will not correct the shoulder dystocia, but giving an episiotomy or extending the existing one may be required for the operator to gain access into the vagina in order to perform internal maneuvers. When the hand is being inserted into the vagina, the thumb and the fingers should be held together in the shape of a cone, and the third assistant should refrain from applying superficial pressure. In order to confirm whether each of these second line maneuvers has worked, gentle routine axial traction should be applied on the fetal head. If one maneuver doesn't work, then it is important to quickly, that is within about 30 seconds, move to the next, rather than persisting with the same ineffective maneuver for long. One should aim to complete the delivery within 3 minutes. Now, I will describe the maneuvers involving the rotation of the shoulders. During these maneuvers, it is important that the main operator and the third assistant who is applying superficial pressure complement each other by attempting to rotate the shoulders in the same direction, that is clockwise or anti-clockwise. The purpose of applying superficial pressure is to rotate the shoulders to an oblique diameter of the pelvis. Similarly, as an initial second line measure, rotation of the shoulders to an oblique diameter can be attempted by applying direct pressure on one or both shoulders. Let us take this case of shoulder dystocia, where the baby's back is facing towards the maternal left. The operator's left hand is held in a shape of a cone with the thumb and fingers together, because otherwise it is impossible to insert the whole hand into the vagina. And the hand is inserted into the posterior aspect of the vagina, anterior to the posterior shoulder. And one should attempt to dislodge the shoulders to an oblique diameter of the pelvis with simultaneous superficial pressure in an anti-clockwise direction. If that doesn't work, the left hand is withdrawn and the right hand is inserted into the posterior aspect of the vagina, posterior to the posterior shoulder, and one should attempt to dislodge the shoulders to an oblique diameter in a clockwise direction. But this time, the suprapubic pressure has to be applied from the maternal right towards the maternal left. If that too is not successful, the operator's hand is moved upwards to the posterior aspect of the anterior shoulder, and one should attempt to dislodge the shoulders in an anti-clockwise direction by applying direct pressure on the anterior shoulder with simultaneous suprapubic pressure from the maternal left towards the maternal right. It is more effective if the operator's left hand is also inserted into the vagina, that is, anterior to the posterior shoulder, and both hands are used to rotate the shoulders to oblique diameter with simultaneous suprapubic pressure from the maternal left to the maternal right. If the shoulders have been rotated to an oblique diameter and gentle traction has been applied, but still the shoulders remain undelivered, then one can attempt to rotate the shoulders by 180 degrees. This is achieved by applying pressure from the posterior aspect of the anterior shoulder and the anterior aspect of the posterior shoulder, or if that is not possible, applying pressure from the anterior aspect of the anterior shoulder and the posterior aspect of the posterior shoulder and attempting to rotate in a clockwise direction. This 180-degree rotation of the shoulders brings the former posterior shoulder, which is already in the sacral hollow anteriorly, to below the pubic symphysis, and the former anterior shoulder, which was impacted behind the pubic symphysis posteriorly to the sacral hollow, thereby enabling the delivery of the shoulders. Now, I will describe the maneuvers involving the delivery of the posterior arm. Suprapubic pressure should not be applied when attempting to deliver the posterior arm. The thumb and the fingers of the left hand should be held together in the shape of a cone, and the hand should be inserted into the posterior aspect of the vagina, anterior to the posterior shoulder. Lifting the head slightly upwards will help. Once the hand is inserted into the vagina, if the arm is flexed, the wrist should be grasped and the arm should be delivered by sweeping it across the baby's face. If the arm is found to be extended, one should follow the arm up to the elbow and by placing the thumb on the cubital fossa and two fingers on the forearm, the arm should be flexed. Once the arm is flexed, the wrist should be grasped and the arm should be delivered by sweeping it across the baby's chest. During the maneuvers involving the delivery of the posterior arm, it is important not to apply traction perpendicular to either the forearm or the arm, because this may lead to fractures of the ulna and radius or the humerus. Traction should be in line with the forearm. An alternative method of delivery of the posterior arm
especially in severe cases, is to apply traction on the posterior shoulder along the sacral curve. This is achieved by lifting the baby's head slightly upwards and placing the index and middle fingers of the operator anterior to the posterior axilla and delivering the arm in this manner. This has the additional benefit of reducing the effective transverse diameter at this stage because the presenting diameter now is acromio-axillary rather than biacromio. A sling may also be used for this purpose. In fact, delivering the posterior arm in this manner is easier, far more effective and less traumatic than delivering the arm across the fetal chest. Even after the posterior arm has been delivered, if the shoulder dystocia remains unresolved, the baby's head should be supported and the trunk can be rotated by 180 degrees by applying pressure on the anterior aspect of the posterior shoulder. This brings the former posterior shoulder now anteriorly to below the pelvic symphysis. This should enable the delivery of the shoulders. If the internal maneuvers have not worked, there is a place for placing the woman in all fours position. This position causes a 1 to 2 cm increase in the anteroposterior diameter of the pelvic inlet. If the shoulders remain undelivered, even after placing the woman in this position, one can attempt to perform the internal maneuvers again. In this position, it is the posterior shoulder that is delivered first. However, this position may not be feasible if the woman is obese or is on an epidural. After all the above mentioned measures have been tried, if the shoulder dystocia still remains unresolved, any one of the third line measures can be attempted as a last resort. These are cleidectomy, that is cutting or causing a fracture in the clavicle, symphysiotomy, provided the expertise is available, or Zavanelli management. Cleidectomy is difficult in a live baby. Furthermore, it can damage the subclavian vessels. However, it is feasible if the baby is already dead. In Zavanelli maneuver, uterine relaxation is achieved by administering 0.25 mg of terbutaline subcutaneously, and the processes of delivery of the head are reversed by first rotating the head to an occipital anterior position and then flexing the head. This is followed by replacing the head in the vagina, and the baby is delivered by cesarean delivery. If the baby's head cannot be replaced high enough in the vagina to allow a cesarean delivery, then after making the incision on the uterus, the anterior shoulder can be directly rotated into oblique diameter, and another skilled operator can perform internal maneuvers in order to deliver the baby vaginally. Once delivered, the baby should be handed over to the neonatal team for resuscitation if necessary, and also to look for possible birth injuries. Cord blood gases need to be done. The woman should be examined for any perineal tears, and one should also anticipate postpartum hemorrhage, which may occur as a result of genital tract lacerations or uterine atony, characteristic of a prolonged labor. In summary, the majority of shoulder dystocias can be managed by shifting the woman to the lower edge of the bed, macrobus position, and suprapelvic pressure. If these first line measures fail, internal rotation of the shoulders to an oblique diameter of the pelvis is the next most feasible option.
If that also fails, whether to go for rotation of the fetal shoulders by 180 degrees or delivery of the posterior arm mainly lies at the discretion of the operator. However, upon inserting the hand into the vagina, if the posterior arm is flexed, then delivery of the posterior arm, or if the arm is found to be extended, then rotation of the shoulders by 180 degrees is reasonable. The all-force manual is useful. When it comes to third land manuals, cleidectomy is the most practical if the baby is already dead. Symphysiotomy or Zavarelli manual, which is associated with considerable maternal morbidity, is justifiable only if the fetus is alive. I hope you found this video on the management of shoulder dystocia useful. Thank you for watching.